joining. Got it. Welcome, welcome. So here we are, and tonight we're going to be learning from Dr. Ian Mitchell, and the title of tonight's presentation is Ketamine, from Anesthetic to Antidepressant and Beyond. I'm one of the co-hosts here this evening. I'm Dr. Jenna Creaser, hailing from working and playing and living between Cortes Island and Cumberland, which is the traditional unceded lands of the Comox and Klahoose First Nations. And this, as I was explaining just earlier, is sort of a grassroots initiative that we started in the fall with the goal to help increase education awareness and acceptance of psychedelics as a potential emerging treatment option for psychiatric illness and beyond. We have a lovely series of presentations. Many of you have joined some of our other talks that were happening in the spring, and we'll be meeting for the next several Wednesdays, second Wednesday of every month, with a few more talks happening. So please do email Antoinette if you'd like to be on the list for those and you're not already. And I'm here and delighted to be sharing this role with Dr. Rob Comey, as well as Ellie Molnar, who are our psychiatrist co-lead and project manager. And just to let everyone know, the session is recorded, and that way we can share it with those who are not able to attend this evening, as well as if you'd like to review some of the material. But the breakout rooms that we're doing will not be recorded, so that will be confidential and not included in the recording. We will be able to hear from Dr. Mitchell, and then there will be a good portion of time for Q&A. So if any questions arise during his presentation, please just make note of them, and then you can share them by typing them out in the chat. And hopefully we'll be able to address as many of those as we can. We always seem to have lots of really interesting questions. And attendance is recorded, and it's in your favor, if you could please, to make sure that your name is both your first and last name here on Zoom, and you can change your name to reflect that. But the best way is actually to complete the attendance survey, and there's a link for that provided in the email, as well as the Google invite, and Antoinette has kindly just placed it there in the chat as well. And so, yeah, without further ado, I will introduce our presenter this evening, Dr. Ian Mitchell. And he's currently in Kamloops after training in emergency medicine at McMaster, and he worked in both St. Paul's, Vancouver, as well as overseas in Abu Dhabi. He's currently on staff at the Royal Inland Hospital, and he's clinical associate professor in the Department of Emergency Medicine at UBC. He is a cannabis clinician and researcher, as well as a frequent first aid provider at the Burning Man Festival. And he's been using ketamine in his clinical practice for 25 years now. He's also on the board of directors at catacanada.org, and this is a nonprofit organization which is devoted to increasing access to ketamine. So Ian, thank you so very much for being here with us this evening, and I will hand it over to you.
My pleasure. Well, thank you for such a great introduction, and for having me on for these sessions. I think these are so innovative and really the right time to spread this knowledge. So thanks again for having me on. So let's dive right in, and I'm going to share screen here, and that one there. There we go. Is that looking okay there? Perfect. All right. So title of my talk is Ketamine from Anesthetic to Antidepressant and Beyond. And this is a talk with a bit of a travel log, some personal history, and hopefully a lot of useful information for you. So I hope you enjoy it. Just to introduce myself, I don't know that I need to do much more. It's pretty much gone all over. There I am here in Kamloops on the unceded territory of the Secwepemc Nation. That's a picture from our house of the hospital that's in here, Kamloops. You might be able to see a rainbow heading down there. And I would warn anybody, if you see a pot of gold in the hospital at the end of a rainbow, it's probably full of pee rather than any gold. As far as disclosures go, I'm on the board of directors of Canada.org. This isn't a paid position. This is a nonprofit corporation, and I donate any speaking fees that I make from ketamine talks to this organization to help fund increasing access to ketamine. And if anybody's interested in participating more in policy or kind of advancing ketamine in clinical use, please contact us, and we'd be happy to have you help out in our organization. So, outline of this talk, I'm going to start off with some pharmacology. I'm going to go through a little bit of history and the emergency department usage of ketamine. We'll kind of take a little nasty break and talk about safety concerns. We'll talk about ketamine-associated therapy and some regulatory issues to finish up with. And hopefully we'll have lots of time for questions in the end. All right, so away we go here. So part one is just about the pharmacology of ketamine. What is this drug and how do we use it? And I think this is maybe the most important slide I've got, which is why I made it look like it was drawn by a 7-year-old. What this is if you're giving intravenous ketamine, and the lower scale is the dosage from 0.25 milligrams per kilogram, 0.5 milligrams per kilogram, and up to 1 milligram per kilogram. And you see at low doses, at around 0.2 to 0.25 milligrams per kilogram, so a dose of 15, 20 milligrams intravenously, that's a great dose for producing analgesia, for taking away pain. It doesn't necessarily mess with people. They don't feel disoriented or dysphoric. Once we start pushing the dose up to 0.5 milligrams per kilogram, that gets into kind of what people are doing recreationally. They're looking for a little bit of energy, some pain management, and some, borderline hallucinatory activity. So that's a good kind of recreational dose. Going any further up from there really gets into what we call the subdissociative dose. And a lot of people find this unpleasant, particularly if they're not prepared for it. This is a great time to do therapy, but people really need to be prepared because this is the time when people aren't fully dissociated and they're really feeling kind of some possibly unwell or dysphoric symptoms. So that's the time when people are going to have emergent symptoms after I've done a procedure on them. So when I do this, as far as giving them intravenous ketamine for a procedure, we're going way up on this, right up to the top, pretty much instantly. So we're passing through all these phases. But as people are coming out of it, they're going back down, okay? And they're passing through each of these stages. So at around this stage, when they're passing through that stage, that's when people are going to have the emergence phenomenon. But it's important to understand that people go up and they go down with their blood levels. So when they're starting up, if you're doing IM or intranasal absorption, which may be a bit slower, that there's potential for people to go through all these phases right up until dissociation. The other really critical thing about this graph is this maximum. And this is very important for people to understand that, once I give someone 1 milligram per kilogram of IV ketamine, there's no more clinical effect to be gained. I can keep on giving higher and higher doses of ketamine, but I'm not going to get people any more dissociated. All I do is prolong the effect, okay? And that's fine if you want a longer effect, but you don't get that much more benefit by giving larger doses. You just prolong the effect of the medication in that dissociative state. All right. So this is really kind of important to understand, this whole ketamine continuum, that people will go from analgesia into kind of weird space and then fully dissociate where they're really not responsive. Okay. Talking about the bioavailability, when on that last graph, the doses I'm suggesting are intravenous. So there's 100% bioavailability. Intramuscular comes pretty close, comes up at 93% bioavailability when you give it as an IM shot. But the absorption drops significantly if we go into intranasal. That's also compounded by the lack of ability to give large amounts of fluid when we're giving it intranasally. Sublingual, we're dropping down to 25%. And part of the problem with sublingual is often people do swallow some of it and get down to PO absorption, which is even less efficient at only 17%. Plus also with the first pass effect, there's generation of a metabolite called norketamine, which tends to be much more sedating than ketamine does and kind of gives people more of a body stone feeling and often not as good as far as pain management goes. Okay. And within the pharmacology, we need to talk about this medication called esketamine. And esketamine is a medication developed by Janssen Pharmaceuticals, and it is one of the isomers of ketamine. So all ketamine is made up of R-ketamine and S-ketamine, and these are mirror image molecules of each other. Let's going back to some perhaps unpleasant inorganic chemistry memories for people. The question is, do these different enantiomers, do these different forms of ketamine work any differently? And the research that the drug company paid for kind of showed that it probably did work better for depression. But you got to keep in mind who the funding is coming from. And there's other companies that are developing R-ketamine. And you say, well, what's necessarily so much better about S-ketamine or R-ketamine? Well, the only thing that's really better is you can charge lots of money for them. Okay. Regular old ketamine is off patent. You can make anything, you can give that off label, and it's not very expensive at all. It's honestly pennies to give to people. But Spravato, full treatment can run up to $600. And why is the price so high? Well, their feeling is that, well, if we're using this to treat a depressive episode, to treat somebody who's suicidal, well, we can avoid a hospital admission, which would cost more than $600. Therefore, the market will pay that money. And obviously there's insurance coverage, whatever, but it tends to be much more expensive than generic ketamine. So, but this is kind of obviously sponsored by drug companies. There's a number of psychiatrists who have been trained in using this medication. So it's certainly out there, and I don't have a problem with it being used, but it's, it's definitely a pharma product, and has certainly the cost associated with it, which I think is the biggest problem arising from its use. So both ketamine, esketamine, and PCP, Ibogaine, and dextromethorphan, these are all medications that are in the same class of family, that they all antagonize the NMDA receptors in the brain. Those receptors are very important for mood, for memory, for pain management. So any of these medications could potentially be used in place of ketamine, but obviously they all have their own characteristics and issues that arise from them. And it's hard to sound like anybody could be positive about PCP. This is a legendarily awful medication, with horror stories about people breaking things and incredibly aggressive behavior. But remember that graph I showed you a few slides ago about going up and going down from dissociation into subdissociative state and dysphoria. The thing about PCP is it lasts much longer than ketamine does. So with ketamine, you might go through that phase in 20 minutes, 30 minutes. But imagine if you were in that phase for hours. You can see how this could be a real problem. So the real problem with PCP is not something that's that much different than ketamine. It just lasts a whole lot longer. So the potential for unpleasantness is really magnified. And potentially sometime we'll find a better way to use this. I want to mention Ibogaine, because it also acts on NMDA receptors. And it's another psychedelic. I don't know if it's been brought up in this series. It's bark from a tree in Africa, and it's used to get rid of withdrawal symptoms from opiates. So people take this medication. It produces an intense, long-lasting hallucinogenic state, complete with copious vomiting. But in the end, you wake up and you don't have any withdrawal symptoms from opiates. Okay, so that's something that we don't see a whole lot of. But it's the main reason for using Ibogaine, using Iboga. But the interesting thing is that's also been reported from ketamine usage. And I've actually had that experience of having a patient come in who was on a large amount of narcotics, and she had worsening back pain than normal. And I gave her some ketamine, and I didn't think too much of it, but I was just trying to get something that would help her pain because she's already on a lot of opiates. So I gave her a good dose of ketamine, and she said, that really helped. And I saw her about 6 months later, and she said, the first ketamine treatment you gave me in the emergency department worked so great. And I went back and I begged them to give me another one. And this was still very kind of experimental for our department, but she found one of my colleagues to give it to her. And she said she walked out of there after that visit and she threw away her opiates and she hadn't used them since. And she was on large doses of Dilaudid. And this experience is known in the literature. The British government used to send plane loads full of people to Germany for ketamine comas to help them with their opiate withdrawal symptoms. So this phenomenon of burst treatment of ketamine where you can decrease the usage of opiates for a long period of time. Another medication that acts on NMDA receptors is dextromethorphan. And on the street community, it's known as poor man's Ibogaine. Because again, similarly, you can take large doses of dextromethorphan in an attempt to wean yourself or get rid of opiate withdrawal symptoms. So this kind of brings me to potentially a great use of ketamine in opiate addiction, because there's this phenomenon of opiate-induced hyperalgesia, where opiates, when taken over a long period of time, can really increase the pain you suffer. So at that point, even if someone's taking your blood pressure or doing a needle stick take blood, you react as it's incredible agony because your brain has changed in the way it perceives pain. And this is driven by NMDA receptors. The reason there's a picture of House on this is this was used as a plot point in one of his TV shows, that he was in an accident, he had some surgery, and they gave him ketamine during the procedure to try to defeat his opiate addiction. So the question is, well, not everybody gets opiate-induced hyperalgesia, but some people do, and a significant portion of people do. So for those people, if they have this dysfunctional system, well, it's natural for them to want more and more opiates because it's the only thing they perceive that makes them better. But in the end, it's making them worse. It's making their brain perceive the pain more intensely. So my question is then, well, should we be really focusing on these patients with ketamine treatment or some other NMDA receptor? And should manipulation of these receptors be part of any opiate dependency treatment as much as Suboxone or methadone are? Because if we could take someone in tremendous pain and reverse that so that they were in their original state, then they'd be in a much better position to get out of their dependency. And this is speculation at this point, but it really seems to fit and really seems to have a place in this treatment. So a little bit of a travelogue, a little bit of personal history here, and we're going to talk about the emergency use of ketamine. And I started off my training in Hamilton, Ontario. Nice, beautiful spot there. When I was training in the emergency department, we were not allowed to use ketamine. Emergency physicians were not allowed to use it by the anesthesia department. They felt we were not competent enough to use it, didn't know what we were doing, and would only get patients into trouble. But subsequently, I moved to Vancouver, and in Vancouver, we were allowed to use it. So obviously, it's a very regional kind of thing. It depends on your department, but we were allowed to use ketamine in our department, and it became the drug of choice for a particular procedure. And Vancouver is a very beautiful city, but as you can see on this picture here, when you get down just down to the left-hand corner of this picture, we get into the downtown east side, one of the highest concentration of intravenous drug users in North America. And one of the things they would get is, and this is to some extent before a lot of harm reduction supplies were available, so people weren't getting needles, clean needles, that sort of thing. So abscesses were very common. So people would come in with big abscesses in their forearm that needed to be drained. And you could give them morphine and fentanyl, and nothing happened because these people are all hardened opiate users. So there was very limited option in how we could give them sufficient pain management in order to drain these abscesses. And ketamine turned out to be the answer because they weren't used to that. You could give them ketamine, they'd go down, and you'd be able to fix them properly and deal with the procedure. But there's a real downside. When probably more than average, particularly these intravenous drug users came out of their ketamine anesthesia, they would just have the worst emergence reactions. And I'd hear stories from people after they'd had the procedure. I went to hell and the devil was sticking a pitchfork in my belly and tearing me apart. And, it just, it made a lot of people not want to use this medication. However, it did become our standard for trauma, for intubation, because it's so safe, because it doesn't decrease blood pressure, like fentanyl, like propofol, other agents we'd use to induce a patient for intubation. Particularly in trauma patients, often we're worried about them bleeding out. They've got low blood pressure already. So ketamine helps preserve that blood pressure and is a great medication for treating these patients. Subsequently, after 5 years at St. Paul's, I took a little break and went to Abu Dhabi to work at the Sheikh Khalifa Hospital. And as opposed to St. Paul's, this hospital treated lots of children, and lots of children in Abu Dhabi tend to fall off things and fall on their faces and get lacerations. And so ketamine is our choice of medication. It's given at a pretty high dose. It's usually 4 milligrams per kilogram IM. Not a pretty sizable dose there. And they really go out for that. So that gives you a chance to have them lay still while you fix up the laceration, take the bead out of their ear, or whatever it is you got to do. And this is the first time I'd given ketamine to kids. And the thing is, they just had a completely different reaction from the people back at St. Paul's. They would see Barney coming out of the wall and they just think that was great. I walked into one room and this kid he was kind of flexing his hands, and I wasn't sure if he was having a seizure or he was just kind of doing this twitching with his hands. And I said, what's going on? He looked at me and he said, "I'm Spider-Man." So they just had a much better experience, and kids overall accept this unreality, this distorted reality much better than adults do. So they're much easier to treat with ketamine, much less likely to have emergence reactions. But that really brought to the fore this idea for me of set and setting, which I'd never really considered in terms of ketamine, but applies as it does to other medications like LSD and psilocybin, that the set, how you're feeling going into it, can play a big role. So for people who were these intravenous drug users, they knew they were going into a facility where people stigmatized them or people didn't treat them properly. They knew they were going in to get a painful procedure done. And they're coming from a life of horror and torment. So it's kind of natural that would be their response in coming out. They'd revisit that place. And to some extent, you can reverse this or help with this by suggesting to people in advance, making pleasant suggestions, telling them to think about being on an island, and giving some visualizations to do. But most physicians don't really do that because it's not something we're used to in terms of these kind of medications. Obviously, in more psychedelic settings, that's a natural. But for a lot of times, I'm giving this medication to people. Well, have a nice trip and off you go, kind of thing. So that's about as much pre-coaching as they get. And setting obviously plays the other role. And as I was saying with the intravenous drug users, they're in a very bad place. Things are awful. So when I, now having learned this kind of idea, when I'm done with the procedure, we turn the lights down. We try to turn off all the machines that are making the bing noise. We encourage the patients to play some music if they'd like, or with their family with them. Just to make the experience more pleasant when they're coming out and decrease the chance, because you can certainly make it unpleasant. So after Abu Dhabi, I ended up returning to Kamloops. And at this point, I'm still doing predominantly emergency medicine and using ketamine for procedural sedation, for laceration repair, for trauma type of thing. But I hear murmurings in the literature about ketamine for depression. And it turns out they found that if they were anesthetizing people, having people do hip surgeries, but they gave them ketamine, that they seem to be less depressed afterwards. So this kind of clinical effect was noted, and kind of started research in rats, and on it went, to the point where it's been pretty firmly established that ketamine produces an antidepressant effect that takes place within a few hours and lasts for days, often up to a week, 10 days kind of thing. But that's about the length of effect you're going to get. So I need to kind of learn a little bit more about this. So I was looking for kind of anesthesia conferences and emergency medicine conferences, but nobody was really talking about this. So sometimes you just have to go to the proper place, and it turns out to be MAPS, which is the Multidisciplinary Association of Psychedelic Studies organization. And they have a conference every year. In the past, it's been in Oakland, and it's been a great place to do some learning. I believe the next version is going to be in Denver, Colorado. So hopefully look forward to seeing some of you there. It's a very different kind of thing. This was not the normal kind of conference floor that I normally visit, but there you go. It was a very mind-opening experience, and I heard a lot about ketamine use from around the world, and realized it was already being used in places like New Zealand. Because this is what I've wanted. I've wanted something that I can help people who are suicidal when they come to my department, because this is the help I have to offer them a lot of the time. They're suicidal. I'm worried they're going to take their life. So they get to go into a locked room. We take their clothes, we take their cell phone away. They're not exposed to any natural light. And then, well, yeah, is their mood any better? Generally not. They're safe, but I wouldn't say they're any improved. So to think that we have a treatment now that you could give to someone and make them better within hours, so that instead of locking them in here, you could say, well, you know, go home and you're going to see the psychiatrist in a couple of days. You know, that's just a far more humane treatment, and something I would hope to offer patients in the future. And then we get into some of the kind of odder things. Look, we use ketamine for everything. It's like our coffee kind of thing. So asthma, for status epilepticus, seizures that are out of control. If patients are on Suboxone, methadone, we have difficulty controlling their pain, we're going to give them a ketamine infusion, maybe 15 milligrams an hour. And that is just excellent for their pain. This is very useful in trauma patients as well. If we've got to take care of a wound, scrub out some road rash, we can give people low dosage and they'll sit there just having a little chat while you scrub out their wound. Behavioral control is something I learned out at Burning Man, giving large doses of ketamine to people. And the dosage we're talking about is 4 to 5 milligrams per kilo. So often 400-ish milligrams of ketamine. And as I said, that's going to dissociate someone really over the top and for a good length of time. But it is very sound, it is very fast, and it is at the moment the best way we have of controlling an out of control agitated patient in our department. One of the issues that has come up around this is that in America, some of the paramedic services use this and have been kind of using this at the direction of the police for perhaps not ideal medical needs. And there's been at least one death from ketamine in the community down there. And I couldn't leave this emergency medicine portion of things without talking about Gary Andolfato. And he's an emergency physician in North Vancouver. And he was out, as any emergency physician is, he's an avid mountain biker and was out on the North Shore Mountains. And he fell and he broke his femur. And he didn't have a cell phone with him. And he had to hike, I believe it's 7 kilometers with his broken femur using his bike as a crutch before he could get to anywhere to get some help. And they called, an ambulance came, he thought, well, great, now I'm going to get some decent pain medication. Turns out they had nitrous oxide, laughing gas on board, no morphine, nothing else. So it turned out to be a bumpy, painful ride for him. But during the ride, he thought there's got to be a better way. So he designed a study to look at the potential for giving intranasal ketamine to patients in the ambulance. Subsequently ran the study out of a Surrey ambulance station, and now it's standard of practice in BC for paramedics to have intranasal ketamine on board for pain management. So those are all the good things, and you know, I hope that's kind of opened everybody's eyes to the extremes of ketamine and all the things we use it for. But I'm never going to say that it's not without its concerns. Certainly some of those concerns were overblown, and we got some of these myths from anesthesia. And one of the first ones was about intraocular pressure, that ketamine would increase your intraocular pressure, so it couldn't be used in people with glaucoma, couldn't be used with anybody with eye injuries. And that turns out to be a myth. Multiple studies since that time have not shown any consistent increase in intraoral pressure or intraocular pressure. Similarly, with increased intracranial pressure, it was felt that, okay, with head trauma, with someone who might have a head lesion, any edema in their brain, that you couldn't use ketamine. So for head trauma, it was right out. And again, that's completely gone and been reversed by subsequent research. Psychosis. Some of the guidelines kind of caution against using ketamine in schizophrenia, citing that you may make the hallucinations worse, delusions worse. It seems that that potential is there while you're actually giving the treatment, but there's no kind of long-term worsening of any effect. So certainly if someone's having hallucinations before you gave them ketamine, they'll probably be more intense when they're having the ketamine, but it doesn't produce any longer-term issues. And once it wears off, they return to their previous state. Blood pressure. I'm going to spend a little bit of time on this because it's something I spend a lot of time on in the emergency department in general. There's no shortage of people who show up in the emergency department with elevated blood pressure and no other symptoms. And they're very concerned that somehow their brain will blow up, that their head's going to explode because of this untreated blood pressure. So I have to spend some time educating them and talking about blood pressure being a long-term problem, that acute changes in blood pressure are not going to be a big issue for people. That when they go to the gym, if they do a leg press machine, their blood pressure is going to go up to 300 and nothing bad happens, because it's really about the long-term effect of elevated blood pressure. So there's guidelines now from a variety of areas looking at blood pressure issues with ketamine. And some of them suggest that you shouldn't give ketamine to anybody with a blood pressure above a certain level. And some of them suggest that if you do give them ketamine and the blood pressure rises to a certain level, that you should give them medication. And I find this very, very problematic. And the reason I find it problematic is that we're not really treating any disease. We're treating blood pressure, which is not a good proxy for disease. Blood pressure can be elevated many times without causing any problems. Even if someone comes in the emergency department with elevated blood pressure, my response is you should see your family doctor within 3 months. So to give a medication that's going to last 4 to 6 hours, like Adalat, Captopril, seems counterproductive and potentially harmful for a medication that's going to wear off in an hour. So I'm very uncomfortable with some of the guidelines that are around recommending treatment for high blood pressure. And I'm not really clear that people need to be concerned about this, but I'm happily willing to be corrected if anybody knows of any concerns that have actually happened relating to increased blood pressure from ketamine. More realistic complications, vomiting. Vomiting is not uncommon with ketamine. People have had issues with sedation before, with any problems with ketamine before they may be treated with a Danstron. And that's not going to impair the experience at all. So it works on a different receptor system. Laryngospasm. Laryngospasm is the real big concern for most people. It is more common in children. It is more common if you're doing a procedure around the mouth or any kind of trying to get something out of a mouth or a nose kind of thing. There are 2 real ways to fix laryngospasm. Generally, it can be broken with bag valve masking, but it really has to be done by 2 people. It's very difficult for one person, unless you are well practiced, to get a good enough seal to be able to break it on its own, because you really need that pressure. So it's important to be able to have 2 people who know how to apply the mask and do bagging, and that can break this laryngospasm. There's also a maneuver called the Larson maneuver, and I'll kind of demonstrate it. I don't know if people can see me here, but if you can see me, basically you kind of drop your jaw down, and just under your ear, a little hole's going to open up. And if you press in between that and kind of try to make your fingers go together, it gets increasingly painful. And it also helps to push the jaw forward. So between those 2 things, that's going to break laryngospasm as well. So anybody who's using ketamine should really be familiar with how to deal with laryngospasm. I haven't seen any cases of intubation being required, so I don't think it's necessarily appropriate or needful to have full intubation equipment available as opposed to just a bag valve mask. But again, I'm happily willing to be correct if anybody knows of other literature to not support that. One of the kind of interesting side effects, more in terms of long-term usage, is ketamine cystitis. And this became known predominantly in the UK and in Hong Kong, where there's high proportions of people who are ketamine dependent. And it was found that the ketamine would produce a condition very similar to interstitial cystitis, with pain, ongoing bleeding, feeling like symptoms of urinary tract infection, and sometimes so severe that people's bladder had to be removed and they had a diversion procedure. Okay, but again, that's people typically using grams a day for months, kind of thing. But I think it's important for us to remember and kind of encourage people, if they're doing regular ketamine treatments, it's probably a good idea to pee right afterwards. I mentioned before about giving big doses to people. And we give these doses of 400, 500 milligrams IM to people, and it's okay. They generally do okay. Occasionally, we have to look after their airway. So I wasn't sure if there's ever a maximum dose of ketamine, but this journal article really tells a horrific tale about a military physician who was injured in training exercise, had her elbow dislocated, and ended up in an emergency department with a physician who wasn't clear on the usage of ketamine. And she realized how out of the water he was just as he gave her a 600 milligram IV bolus of ketamine. So she subsequently developed hypotension. She ended up in the ICU for days. She had tremendous hallucinations, delusions, sort of thing. So certainly high dose intravenous ketamine is not good for people. And even lower dosage, we often will give in a mini bag, give it over a bit of a duration to avoid dysphoric feelings. All right, part 4 is on ketamine-assisted therapy. And this comes out of an unexpected meeting at Burning Man. I was there one year, and I was there quite late into the festival and just had some extra time in my hands. So I'd go and hang out at the Sanctuary tent, which is run by MAPS. It's where people go if they're having a challenging psychedelic experience. Someone talks nice to them, gives them some tea and talks them down. And it's all very lovely. And there's usually a medical person there who is always someone interesting. So often I'd just pass by and see who it is. And sometimes I knew them and sometimes I didn't. And I sat down and talked to this guy one day, and he was telling me about that he used ketamine for therapy. And I had never heard about this, because my whole thought was, well, you give ketamine to people and then you walk away. And he's like, no, you give ketamine to people and then you talk about it and you help guide their experiences they're coming out and ask how that reflects on them. And I thought, well, what a chump I am. Here I have been doing this for 15 years at this point, and I just let these people wake up and I'm not doing anything to them. So, is this a massive wasted opportunity I've had here? Not that the people I'm dealing with are often in a great position to do any therapy right at the time, but nonetheless. So it's very interesting. This guy turned out to be Phil Wolfson, who's kind of the king of ketamine-assisted therapy, and has written a great book on the topic. And I'd recommend anybody read his book if you're interested in this. But just the power of festival networking. So ketamine-assisted therapy, this is giving the ketamine, but then talking about it, and either talking about it kind of afterwards and reflecting on the feelings and visions that you had. Sometimes it's during the actual experience, people are kind of talking, but often they're kind of out of it, or may not be able to express their feelings at that point. So you may get more out of people afterwards. So there's typically a briefing session or two in advance of the ketamine-assisted therapy. Then there's a therapy session, and there's some debrief and reintegration, just to bring all that knowledge back. So that's kind of what ketamine-assisted therapy is about. And I'm kind of thinking we're going to be seeing a lot more of it in British Columbia now, because things have changed here recently. We'll be more about that. All right. So the problem with the ketamine therapy is that it's expensive. If you've got to have a doctor standing by, if you've got a nurse, if you're doing anything with intramuscular, it gets needles involved. So that's a lot of equipment and needle storage and getting rid of them safely, kind of thing. There's security issues for having ketamine around. So it just all costs money to run a facility like this, to have that kind of supervision. there's monitoring requirements. And, some of the college's early stuff was about, that people should have continuous blood pressure and heart rate monitoring or oxygen saturation monitoring. And that just, it doesn't make any sense. It certainly doesn't make any sense to do oxygen saturation monitoring. Again, I think my feelings about blood pressure. I don't think it's particularly critical or important to look at. And you're probably just better off turning off the monitor and not looking at it. There's been very limited availability for ketamine outpatient therapy. So right now in British Columbia, for example, it's really down on the coast. It's in Vancouver and Vancouver Island. But if you're in the interior, there's nowhere up here at the moment. And similarly in other places in the country, there just are not a lot of places around. Follow-up's a big concern. We talked in our department about giving people ketamine for depression, but then the part of the problem was, well, they're going to have to keep coming back. So if we've got 50 people coming for ketamine and depression, that's going to fill our emergency department. We can't do that. But also we need the psychiatrist to kind of follow up with them because it only lasts for a certain amount of time. And, we want them to get onto other treatments and ultimately not need this therapy ideally anymore. And we also need to work around just what the best modalities are. Intramuscular is probably the best thing to be using for outpatient therapy, but as it evolved, it brings in needles, and that's more complicated than just using nasal or sublingual. And is there a way that we could bridge intramuscular with nasal or sublingual formulations? So last little bit is going to be on regulatory issues. So, previously the colleges have not been super happy about ketamine. They've wanted to kind of hold on to it and really have discouraged any clinics from starting. But things have surprisingly changed. A little bit of history just about the college in British Columbia. That's where I'm from, so it's kind of the history you get. Some of the early policies last year were there was really no non-hospital ketamine allowed. All ketamine had to be in a hospital. And then they kind of came on and they said, well, wait a minute, we didn't mean Spravato. Of course we didn't mean Spravato. You can give Spravato all the time, corporate agenda and all that kind of thing. So that's all good. But everybody was still left in the dark. And up till, honestly, a few days ago, or a couple of weeks ago, about, can I do intramuscular? Can I do intranasal even in the community? And nobody really wants to start up a clinic unless you're feeling that it's likely to be able to go on. It's not going to be shut down immediately from the college. Because there's been notes made of physicians in our community who've said, well, I was approached by the college and they said, oh, are you doing ketamine with your patients? And they'd be like, well, not anymore, kind of thing. So it has certainly had a chilling effect. So now that these guidelines have changed, I think we have an opportunity for kind of the good and bad for just the very expensive ketamine clinics, but hopefully ones that will cater to everybody as well. All right. So going forward, I'd like to see an increased emphasis and awareness of set and setting for ketamine, because I think it comes from the medical paradigm, and not everybody is familiar with that. So I think that it being bridged into the psychedelic and medical community, and I think more people bring that in. But I'm not sure it's kind of there for the large group of physicians being aware of the kind of whole idea of set and setting in psychedelics. I think we have some work to do on standardizing the dosing and the treatment as far as mood disorders, because we're really kind of still struggling with knowing what's the best treatment. How can we extend this treatment? Can we give the ketamine and add psychotherapy, and is that going to make a big difference, or does it make no difference at all to do that? We'd like to set some reasonable guidelines to balance safety and cost. And Canada is kind of in the process of making some recommendations to BC College to help with guidelines. So the questions I'm still kind of wondering about come into are these. In the pharmaceutical industry, there's been great efforts to try to find drugs like ketamine that don't cause hallucinations or delusions, that don't have the psychedelic effect. And I'm unclear if that's going to work. Is the psychedelic experience somewhat necessary to the whole antidepressant effect? is it possible to find other drugs like that? They would, pharmaceutical industry is certainly more keen on that because they just don't want people wandering around in psychedelic trances all the time. And if we could find a drug that didn't have that, that would be more beneficial and probably more acceptable to a large group of population. So my question is, well, but do we have to go there? Is that not important? And maybe we do need to accept that there is real benefit to this, whatever we think of as the psychedelic experience. And lastly, just, to look a little bit more into the world of addiction and the importance of hyperalgesia in addiction, and whether that's going to open up a new avenue for another class of agents that we could be using to help treat addiction. And obviously we're in the middle of a poisoning crisis, an opiate crisis to some extent our own making, that we're still digging our way out from. So there's lots of organizations interested in new therapies, and I'd like to see not just ketamine applied to mood disorders, but more ketamine applied for addiction issues. All right. So I think that's pretty much what I've got to talk about. So I hope that's we can take a pause there and move on to the other groups next. I'll just say as an end, if anybody wants to get in contact, I'm on Twitter at @TravelsTooLittle. And I would also encourage anybody who is interested at all in this field, if you're passionate about this, please reach out and join us at CATA Canada. We'd love to have all the help we can get. Thank you so much.
Thank you, Ian. What a fascinating talk, and so much information that you really presented a lot in a short period of time. So we really appreciate that. Yeah, and so in the interest of time, we will still do our breakout rooms, but we'll actually condense them a bit. We'll just meet in our smaller groups for 5 minutes. And this is just an opportunity to meet a few people in a smaller forum, have an opportunity to connect, introduce yourselves. And within your small groups, our organizers will send out a little button for you to join your breakout room. And I'd recommend someone just keep an eye on the time, since it will only be 5 minutes. And some of the topics you could explore is just who you are, where you're working, what brought you to this talk this evening, perhaps what you found particularly interesting, or any questions or thoughts you may have. And then we'll come back together after that short little break and do a Q&A with Dr. Mitchell. So thank you so much again. And Antoinette or Kirsten, I'll ask one of you to kindly shift us into our breakout rooms, and we'll see.
We're going to get into the Q&A session here. And that, I'm just gonna make sure I see all the participants here and everyone can hear me and see me. Yeah, that's going to run until about 8:25. So we do still have a good amount of time, I believe. So I hope you've posted your questions in the chat box. I've just got to pull that up here, and I will get started, and I'll read those myself just for efficiency. And we'll have Dr. Mitchell answer as many questions as possible. So looking for the first question, I think this one is from Kurt. Do you ever dose an anti-nauseant like ondansetron while treating with ketamine in particular circumstances?
You're muted.
So generally I have a nurse right there who can give an ondansetron right away if need be. Nausea is not that common that I pre-treat everybody. So if someone was like on real vomit comment, or have had nausea with every medication they ever give me, I'm like, sure, let's give you some ondansetron, but I don't do it as a matter of course.
All right. So the next question from Brandon. Hypertension and ketamine I've been taught to avoid in disease processes where acute spikes in afterload can be detrimental. MI, intracerebral hemorrhage, dissection. In the undifferentiated world of emergency medicine, this has made me think twice before using ketamine for all sedations and behavioral control. Curious just to hear your take on this and your emergency experience.
Yeah. So, I mean, I think that the concerns you're really talking about, like dissection and that sort of thing, still are predominantly caused by longer term issues. So even something like an aneurysm, you're not is going to grow slowly. You know, we don't really see evidence of acute elevations in blood pressure causing significant issues, aside from what we call hypertensive emergency. So when we say hypertensive emergency, we're talking about hypertension that's associated with end organ dysfunction. So I think in that case, if there's any chest pain, shortness of breath, yeah, you shouldn't be giving any medication that's going to increase blood pressure. But I've never really considered it when I'm treating a patient who needs to be treated for a reduction, whatever. If blood pressure goes up, it goes up. But it's the blood pressure isn't the disease. And I'm not saying that you know, it doesn't lead to diseases, but I'm not clear that sudden elevations in blood pressure cause disease at that moment rather than later down the line.
Great, thank you. The next question is also Brandon's. He's also curious to hear your thoughts on ketamine IM and PEDS sedation, where you have not established an IV.
Yeah.
What was your policy in Abu Dhabi? Concerns regarding laryngospasm, which sometimes can't break with bag mask ventilation. IM succinylcholine on standby, or always establish IV immediately post ketamine IM. Any evidence on higher rates of laryngospasm with IM versus IV ketamine?
I haven't heard about any evidence versus IV versus IM. It's allegedly more common in kids. I mean, we're still talking about a very uncommon phenomenon, but when you look over all the records, it seems to be more common in children, more common with any ENT procedures. My practice is not to put an intravenous in. Again, we're going to go with the bag valve masking, and I have people right there, so it may be a slightly different circumstance when we're talking about kind of an office setting. But for my purposes, no, I don't put an intravenous in afterwards. We just go with the IM. It's a big dose. You know, typically kids are given 4 milligrams per kilo, and you know the absorption is 93%. So that's a big dose. You give an adult that, they're going to be out for hours. They really do go down well with that dose, but you may not need to give quite that much. So 2 or 3 milligrams would probably be sufficient for most cases. But yeah, as far as laryngospasm, we just give it IM, and I've never had an issue.
Oops, great, thank you. Human's question: have you seen ketamine cause vertigo? If so, how did you manage?
Certainly the spins, or people complain about dizziness, is not uncommon. So typically we're going to treat that with ondansetron or Gravol. You know, one of the things about managing emergence phenomenon, particularly if you're in the emergency department, if someone's having a real struggle, they're really tearing the place apart, whatever, it's like cowbell. You can always use more cowbell, so you can always use more ketamine. Exactly the same. Someone's having a real bad time, you give more ketamine, they're just fully dissociated again. Now you've got time, you can assemble a team, you can grab some ondansetron, some lorazepam, whatever you want, but you bought yourself time by pushing them back down into full dissociation again. Okay, so that's just another thing I kind of wanted to bring up as far as managing the issues that come around.
A question from Luke: any thought or guidance on how people are using ketamine oral for depression outside of the hospital? Is that something?
Yeah, I haven't seen that much. I haven't seen people being prescribed it orally, so I'm not sure if they're doing it. It's certainly better absorbed sublingually or buccally. In New Zealand, they give you these giant lozenges, and you can be like 100 milligrams. So you can only jam like a couple of them in your mouth at one time, otherwise you choke. But here I think you can get oral ketamine. The problem is it does have, through this first pass effect, you get this norketamine metabolite, and that tends to be not as well received as regular ketamine.
Stuart's question, coming from the UK, I've seen ketamine-induced cystitis quite a few times and had a patient who had lost their bladder. I was under the impression that this was an acute risk, even in one-off therapy. In one-off therapy. Do we know much on if it is related to how high the dose is, or as you mentioned, is it only associated with long-term use?
Yeah, my understanding is really only associated with long-term use. I've kind of, when I'm looking around for signs of it, I think in people who've had regular IV infusions, there's been some kind of, okay, well, we might have an occasional person who's getting some irritation there. So those people, we really have to, make sure that they get up as soon as they're done, have something to drink, empty their bladder, kind of thing. And I think that should probably be kind of part of the general instructions that, ketamine is a known bladder toxin. So drink lots of water and make sure you flush yourself out afterwards. Another complication that can come from long-term use is there can be some irritation of the gallbladder tree. And I had a guy come in and he kind of looked the part. He had, the big piercings and the dreadlocks and whatever. And he had right upper quadrant abdominal pain. And, ultimately I said, well, do you ever use ketamine? He's like, oh yeah, all the time. So, don't want to judge a book by a cover, but sometimes it helps. So that's just one other problem with long-term usage.
Okay. This is from Pamela. It sounds like a good test question. If you were getting consent from a patient for ketamine treatment, what would you quote as risks they should consent to?
I think the common things, I think you have to say, well, what's common? So dysphoric reaction is common, nausea is common, elevated blood pressure is common. Things that are less likely could be trouble breathing. That's really uncommon unless you give a massive dose intravenously. I think you have to mention laryngospasm, that it's very uncommon, that we have people here that can deal with that issue. That's pretty much, I think, the talk I give to people. I don't generally talk about the ketamine cystitis or long-term issues because I don't think it's relevant to the thing that I'm doing for most people, which is a procedural sedation.
Sure. From Dale, if ketamine is used for depression with psychotherapy, is there evidence to support effectiveness and less frequent use than every 10 days?
Yeah, that's I think the literature we're waiting for right now to see, because we'd love to have this effect sustained for as long as possible. So I don't know if there's another, if there's a supplement that can be taken along with it, if it's going to be the talk therapy that really adds on. But I haven't seen any literature support that so far. But that's what we need to see.
A question from Kirk. Can you describe the perfect scenario where you would go to ketamine as a treatment for a patient with depression or suicidal ideation, as opposed to standard treatments?
Sometimes I would say that, my ideal patient is a pediatric patient with asthma and a broken arm and depression, because then I can fix all those things with one medication. As far, sorry, I should probably get the question again.
Yeah, it's a perfect scenario where you would go to ketamine as a treatment for a patient with depression or suicidal ideation, as opposed to a standard depression treatment.
Yeah. So generally, ketamine is recommended for treatment-resistant depression. So generally, you should try other medications. I've got no problem with that. But there's a lot of people that the SSRIs don't work for. SSRIs were originally better tested for anxiety than depression, but the market was full of anxiety drugs at the time, like Valium. So they kind of marketed it more as antidepressant medication, even though they're less effective, certainly, than the tricyclics. So there's lots of people out there now who have treatment-resistant depression. So for them, the option is ECT or ketamine, and I think ketamine's probably the more humane way to go, if at all possible.
Right.
And I think the other real instance that comes up is with that acuteness, because we know that SSRIs take about 2 weeks to really have onset. So it's like, okay, well, here you go. See you in 2 weeks, wait till your depression gets better, as opposed to, is there anything you do for you right now?
Yeah, the acutely suicidal patient, I think, is the one that's been
So,
mentioned.
and that's, you know, I'd love to do that, but then it's also, well, is that acutely suicidal patient in the emergency department, is that the right time to give someone ketamine? Their setting may not be, the setting may not be the best place. Even for resource utilization, that means I got to take a patient from the psychiatric area of the emergency department into a more acute care because they're getting an IV and some monitoring kind of thing. So it can be resource intensive as well to kind of make that shift. But ultimately, it's the thing that would be best for the patient.
Yeah, thanks for the context. Just make sure I'm in the right spot here. Yeah, Pamela, the person that died from ketamine treatment by paramedics in the US, what was the cause of death? As I understand that ketamine is very safe.
Yeah, ketamine is very, when you're given these large doses, there is a significant number of people who do need to be intubated or have airway support. So that's was really the cause of death. Complicated, I mean, they would say it would be excited delirium, which is kind of a law enforcement term for someone who's out of control, then they all pile on and they die. So that's really the circumstances of this death. That patient was given ketamine, forcibly restrained and died. So that's been a bit of a kind of cause celeb down there for questioning whether or not this should be used. But it seems like it's more when it's being used at the behest of law enforcement rather than at the behest of the paramedics.
A question from Luke. Any guidance for patient using sublingual ketamine outside of hospital for depression?
So you're going to need a pretty high dosage. So it's often going to be kind of 100 milligrams, 200 milligrams for sublingual dosage. There's pharmacies in San Francisco that 3D print lozenges to specific doses now. So, I mean, the technology is very much improving now. So, and there's one of the arguments that comes up a lot in these offices about take-homes or carries. So do you give someone sublingual lozenge to take home to sustain their effect, or demand that they come in each time? And that's kind of obviously a controversial thing about whether the college is going to allow that or whether or not you as a physician are comfortable doing that.
A question from Pamela. Do you have experience with First Nations patients with acute suicidal ideation and ketamine treatment in the ER?
No, I haven't had that experience. I'd love to be using it for acutely suicidal patients, but we just don't have the setup for it at the moment. For First Nations rather, and we're certainly kind of, you know, approaching First Nations groups within Canada for support and for kind of cooperation.
Okay. Question from Jenna. Are concerns with using ketamine at high doses, any concerns with using ketamine at high doses in a patient who has a history of psychosis?
Yeah, so the psychosis thing seems to be an issue. I mean, if you're giving high doses, it's not really going to be a problem because they're going to be dissociated. And when they come out, they're going to take a while to come out, and they may have some emergence phenomenon. So that's the point where you're probably going to be more concerned. Once they're out of it, they should be pretty much back to normal. There's not really evidence to support that giving people ketamine worsens their symptoms, their schizophrenic symptoms, for any longer than the ketamine is in their system for.
Great, that's helpful. A question from Holly. Could you recommend any studies or articles showing good evidence of the effect of ketamine in patients with suicidal ideation, looking at short and long-term outcomes?
We've got a lot of stuff on the Canada website, so that's probably a good place to start.
That is it for questions.
Oh, I got one more here. Dexmedetomidine or clonidine to temper the emergence, which is not a bad idea. Dexmedetomidine certainly is more sedating, would probably be the most appropriate. We tend to give, or I tend to give, emergency physicians tend to give ketamine a lot of the time with propofol. So if I'm doing a sedation in anybody but a kid, I'm always giving them propofol because it makes the ride so much better. Propofol overall is just a lovely medication, makes people want to marry you and tell you their darkest secrets kind of thing. But it really does help the ketamine ride work a lot better and decrease the amount of emergence phenomenon. People just have a much better time. So So typically I'd be using kind of 1-to-1 dosing of ketamine and propofol, so about 40 milligrams, 60 milligrams kind of thing. Often I'll start off with the ketamine, give them 20 to 40 milligrams because it lasts a lot longer than the propofol does. And then I'll start giving them propofol in bigger amounts until they're nice and relaxed, and then we do the procedure.
There's another question here from Jenna. Curious if we can expect the cost of Spravato to decrease.
Yeah, I'd hope so. I mean, in America, it's whatever the market bears, but here I would expect that the cost is going to come down, especially if we see more generic ketamine on the market, because there's not really a reason that anybody could market a generic sprayer of regular old ketamine and market that as an alternative to Spravato.
Those are the questions I see, unless I've missed others. Does anyone have any last questions to enter into the chat? Does not look like it. Thank you so much for that. That was extremely helpful. Yeah, thanks for all of your time, your knowledge, your experience. Yeah, it was definitely an eye-opening presentation.
Well, my pleasure. I'm
thrilled to have you.
And yeah, I'm glad it's recorded. And if anybody has any questions, please reach out, and I'm happy to respond to questions later if anybody thinks of anything different.
I've got another question. If you're
yeah, for sure.
game, just to back up a sec here. The question is from Valerie. What have been the recent changes with the college and ketamine access?
So the College of BC has put out a new interim guidance on the use of ketamine for mood disorders and chronic pain. So it's really about the non-hospital use, and it kind of was much more generous than we had expected, and includes that people can use IM ketamine outside of hospitals. So really, and the monitoring is kind of, their statement is more just kind of be sensible with monitoring rather than having any specifics. So we're expecting, as an organization, Canada to be helping give some further advice to college and come out with a reasonable standard.
Fantastic. Any last thoughts for us? Not to put you on the spot, it's been wonderful. But...
I guess the question right now is whether it's going to be psilocybin or ketamine really out of the gate first here for depression. And, I was thinking with the college before, I was thinking it was going to be that psilocybin was going to be first, just because it's more of a renegade kind of thing. But honestly, it's looking like ketamine is really coming up with the college opening their eyes. So we'll see what goes on. One last question about ketamine for chronic pain. We actually had a little ketamine program in Kamloops here where people get infusions for chronic pain. It got shut down by the college kind of thing, so that's unfortunate. For chronic pain, the hope is that it can be useful for people with chronic pain, particularly those who are taking lots of opiates. That kind of burst treatments of kind of 0.6 milligrams per kilo, 0.7 milligrams per kilo, given over an hour and given intermittently can help decrease people's opiate requirements. So some of that research was done, they used to call it burst ketamine treatment.
And I think Valerie also asked, with respect to the changes in the college, does that also cover ketamine and psychotherapy?
Yeah, I believe it's so for mood disorders and chronic pain.
Yeah, great. Okay, well, thank you again. Again, that was wonderful. So for everyone attending, please do complete the evaluation for the session. The link is in the chat box and is in the invite that you were provided for the session initially. There's also a link for the attendance survey that's entered into the chat box, so you can use that to mark your attendance. Make sure you get your CME credits. We're also going to be sending out a mid-project evaluation on how things are going. We'd like your feedback, what you'd like to see more of, what you'd like to see less of. So that, I think, will come in the next couple of weeks. So keep your eyes peeled for that. The next session is October 13th. That's with Dr. Devin Christie. The title is Psychotherapy and Psychedelic Medications Greater Than the Sum of Their Parts. And so you'll get a registration link for that session in the near future. And again, I just want to say thank you to Dr. Mitchell.
Right. My pleasure.
It has been awesome. And thanks to the participants for your great questions. And yeah, good luck with kids back to school and all that stuff. Take care.
Are the earlier sessions videoed, and where can we find those?
Yes, I will plug them into the chat right now.
Okay, thanks very much. So those are going to be entered into the chat and you can access them there. All right, everyone.
All right.
Have a terrific night.
Thank you.
Thank
Good to
you
see
so
you.
much. Bye for now.
It's just taking a second here.